Good afternoon, and welcome to the last AFIA session. There are 4 papers. There's supposed to be 5 papers in this session, but things keep changing out. I don't know who is doing what. I got information about a week ago that the last paper by Bedasa and Bichaka is not going to be presented because the 2 of them, neither is going to be here. And so we cannot get a presentation. That leaves us with 4 papers. This morning, I got an email from Hanan that she is not able to present her paper. So I'm not sure who will be available to present that paper. If, I don't know, Mohideen, are you going to present her paper too? Do you all hear me?
Yes.
Yeah, yes, yes.
Are you going to present her paper? Okay. What this means is that I want to make sure that we have 4 papers to present. That way I can think about how to allocate time. If we don't have 4 papers, we might have 3. And so if we have 3, each presenter will have 20 minutes to present, and the discussant will have 10 minutes. After that, we'll have 20 minutes for discussions.
Okay, Professor Kwabena, I'm a co-author with Hanan, so I don't have a PowerPoint presentation yet, but if any of the participants are interested in anything we can discuss in the paper as well, I'll be available.
We don't care about PowerPoint presentations, so long as you can tell us what's in the paper and give us a cogent presentation. Yesterday, I didn't have a PowerPoint presentation, but I said something. Okay. If that is the case, we have 4 papers. So each presenter has 15 minutes. That gives us 1 hour. And each discussant has 10 minutes. That gives us 40 minutes. What I'm going to do then is I'm going to be very, very strict with the time. So we have to get ahead right away. Okay. We begin with the first paper. Who is presenting the first paper?
Boris.
This is me.
Okay, Boris, take it away.
Okay,
thank you.
I
am going to be very serious, so you've got 15 minutes.
Okay, thank you, Professor.
All right.
Can you guys see my screen? Can you guys see my screen?
Yeah,
yes.
Yeah.
Okay, good. So this paper is it been now accepted. I think it's going to be in a special issue of African Journal of African Development. So what we're trying basically to do here is it is just kind of in a new wave of things that been popping up now in economics, how now we are living in the age of big data, how we can leverage big data to get economics method, especially econometrics, a little bit more robust. So each of those way of looking at data could benefit from each other. So the way econometrics is more interested in finding the confidence interval after the statistical property of estimates. Yes, that's great, but we usually do that by going with a lot of assumptions and putting specification on our models and choosing distributional things, which is not really the way the big data will see things, more like data driven and more like non-parametric. So I'm trying to apply one of those tools from machine learning to a very known problem in Africa that have been studied very widely, which is the behavior, household saving behavior. And the perspective we are taking here is more on the mobile phone saving. So as we know, private saving drive economic growth, both through the consumption pattern that it affects. It can be through smoothing and things like that, but also private saving also affect the productive investment in human and business capital, all of those things that enter the GDP growth in general. So it is kind of critical at each country level to understand the dynamic of their household saving and how they behave. And we know that critically in Africa, private saving is not channeled that much into investments because we don't have enough understanding of how it's good. And is a lot of people are kind of excluded from the formal banking system. So that exclusion of many is due to transaction costs, kind of related to the banking, the formal or traditional banking as we know it, the risk perception from people, from the household. Most of them maybe don't understand, or they have a very low financial literacy, and then lack of trust. We also have a lot of regulatory barrier that won't allow many of our unprivileged people to have access to banking. So in that way, mobile banking is often an alternative because as long as you have a smartphone and you can hook up with any of those products and you find them interested, you eliminate most of those transaction costs. You find these tools to be kind of easy to use if you have the minimum knowledge about phones. And then you don't have that much of barrier to really have access to that digital economy. So to be clear, it is an opportunity for financial inclusion, right? And if there is a way that we could actually amplify that, that would be great. So that's on the topic side, what is the motivation? Now, on the method side, we pretty much have two cultures of statistical modeling. And that is, Breman is a very widely known guy, statistician, already passed away from UC Berkeley, who was really pioneer in developing a lot of machine learning algorithms. The most well-known is the random forest. So in econometrics and in economics in general, our data generation process is assumed to be stochastic. So we think that there's a randomness in the type of data we are collecting, and we base most of our conclusion on the fact that we can generalize the result that our model is giving us, since what we got as the data is random, and we then maybe not facing any issue to generalize that result. If we have issue with that, we know how to correct for those issues in terms of selection and endogeneity and things like that. So that's really what econometry is trying to do, and we're mostly interested in the estimate, right? So we have a target variable, which is what we pretty much our y variable, and then we assume that the estimate is a joint distribution of the data that we're collecting for input. So this is really the framework that we have in econometrics, and then when we have those variable, those estimates, we want to build around them some confidence, interval of confidence, and then we want to do inference from that. And because of that, we are really interested into asymptotical properties, which basically saying, well, if we're having to generalize our result in a kind of massive data context, our result are still going to hold. So things like consistency will come in, efficiency also will come in, and so on. Now, the second culture is the algorithmic culture, which basically consider the mechanisms where the data is collected to be unknown. We do not know any stochastic. We cannot place any distribution on probabilities around the data generation process. And then we rely on most of the non-parametric way to really uncover what data is telling us. And this has been very surging now as a way to really, I would say, to improve on what we already do as an econometrician, but at the same time to leverage the power of big data that we have right now. Economics can basically use a lot of data right now to do things, and most of the tools that we used to have cannot really deal with those data. And one of the cases that I will show now is really trying to do that. So we approach then the mobile saving problem in Africa from the algorithmic perspective. So we have pretty much 3 questions. The first one is the take-up of the mobile saving product in Africa. So that would basically mean whether you choose one product or you do not choose. So it's kind of binary problem, whether you have it or you do not have it. And then we have the saving accumulation on device. So once you adopt the product, do you actually use it to accumulate saving? That's another question. And as you can see, that's a very continuous problem, and it falls in the category of regression. Now we try to split our data so that we can see any life cycle pattern. For example, when you are in a workforce, when you are already retired, and when you belong to any of those 2 categories. So those are the 3 questions that we're trying to go through using the machine learning. So I want to start with data before talking about the method, because that will help me place things in kind of in context. So this is the survey data, pretty much covering the socioeconomic survey in Western Kenya. It has been started as a population surveillance data collection that was started by CDC, and then with collaboration with my university, Washington State University, they actually overlay to that aspect. They overlay the collection of data on a socioeconomic variable. So it covered 36 villages from Kenya, and the total of 7,700 households were covered. Now, we have selected more than 130 variables, and to use the language of machine learning is actually the features, we call them. And then it pretty much span, all those variables span most of the observable variable that we consider in economic theory to be affecting the saving. So as you can see, if you take our savings model that we know being CQ, permanent income hypothesis, and many other precautionary saving and things like that, most of them will pick any of those big aspects, right? They won't be able to actually pick all of them in the same time. And that's where the problem comes in. Now we have a lot of data, we have a lot of information. Can we, by just using the computational power and those algorithms, kind of put into a model all those variables at once and see which one is coming out? So if you were to do a common econometrics with 130 plus variable with 7,000 household observation, well, I mean, the problem is really, you're gonna deal with most of those penalized aspect that we know, and I will talk about some of them and why they are not the best way to actually deal with that. So our variables that we use here, they are related to family structure, to the demographic.
You have 5 minutes left.
Income, risk, shock, asset, inventory, consumption, and things like that. Now, 3 methods have been used here to penalize, to do the regular regression. So we use the lasso, which is basically using the shrinking parameter. We use the ridge regression, which is pretty much well known in economics, and then the elastic net, which is the linear combination of the 2. So based on the problem that I just said, if we were to use the linear regression, we're going to have a lot of coefficients to talk about. Those coefficients might be very large if actually we happen to have them to be very to have a correlation between them. And one way that traditionally is done in economics. For example, we could use AIC or BIC to actually penalize for the number of parameters we have in our model. However, those two aspects will still require that we actually use a distribution, right? The BIC will basically mean that we need to pick a prior on our estimate to be able to do that. So the penalized parameter in those cases will just be the variance of our data divided by the variance of the prior that we chose. So the choice of the prior is subjective. So who tell us that is actually right the way we're picking the prior and we are right about it. And that's where lasso, ridge regression, and elastic net are coming on, because they are more data driven. And the penalized parameter, the lambda that is picked here, is mostly through the out sample validation. And it happened to actually improve the error rate, to actually reduce the error rate. So overfitting, while it might be something very nicely maybe needed or expected in economics, because we want our data to really to go very well with that model that we actually specify. Overfitting is something that we don't want in machine learning setting. So we try with the lasso and elastic net to actually correct for that. So the result that we find are pretty much confirmatory of what many other researchers has found before. So first, we found that if you own a mobile phone, obviously you're going to adopt on the mobile banking. And the reason for that is the mobile phone basically reduce the expropriation risk and increase the proprietary right. The bargaining power in and outside in household is also something that can actually help people who has actually a mobile phone to adopt mobile banking. And that was a study done by Dupa and Robinson in Kenya, in the same place that we got our data. And they did experimental study there. And then when you own a phone, then you tend to desave. And the reason for that is by having a phone with you, you can instantaneously have access to your money. You can do multiple transactions, and there's no transaction cost, right? So because of that, people who have the phone, if they have the saving account, they tend to actually save more. So compared to, for example, a lockbox or a bank account where you have to face a transaction cost, there's no transaction cost with money, mobile phone, then you can just pick your money and save anytime. So it might not be pretty much a great way to accumulate saving. Now, looking at this is my last slide. So looking at the life cycle aspect. So people who are older, they tend to actually not adopt the mobile saving a lot, right? Probably because they probably have low financial literacy, or they are not attracted to those gadgets. They are part of other generation. They don't know how to use those tools. So younger people, they are more into the mobile phone saving product. However, older people, when they happen to adopt those devices, they tend to keep more money on it than the younger people. So, and again, it will also be related to how easy it is and how many transactions, and also your path of consumption, right? So how frequently, the velocity of consumption, probably young people are more into that than
okay, thank you. Boris?
Yeah, I think that's all.
Okay. All right, thank you.
Yeah.
The next paper, sorry, let's go back to the discussant. Samuel, are you ready?
Yes, please.
Okay, go ahead, and you have 10 minutes.
Thank you very much, Boris and co. I find the paper very interesting, and I was very happy that I was asked to read and then discuss this paper. So basically, the paper is trying to look at the way that people in Kenya, Western Kenya especially, use mobile phone to approach banking system in their community. So briefly, from the paper, what I read is that they try to predict the savings behavior in rural Kenya, taking advantage of machine learning algorithm to examine a massive set of features known theoretically and empirically to affect households' behavior. If you look at the content of the paper, it has objective and motivation, methodology, and then results and conclusion. These areas were all well covered. So the objectives basically looks at savings accumulation behavior. That is what drives savings. For example, looking at human and business, and then capital investment and national growth aspect. And then they look at digitization, if it has some promise for helping in unlocking savings accumulation in Africa. And then the mobile phone ownership comes in there where, as he has presented, the results is very interesting. And basically it talks about owning a mobile phone from their prediction is the most important predictor of household savings behavior. And this is basically through the banking system. And I think this result is obvious because the mobile phone ownership or the mobile banking takes up some of the bottlenecks that the ordinary banking system will prevent the average Western Kenyan from having a banking account. For example, if you have the mobile phone, you don't need to travel to the bank from the distance that you are to have access to a mobile banking. You can activate it through your mobile phone. So that is very important. I will move forward. In terms of theory, I think the paper really captured the theoretical underpinnings of savings accumulation. For example, talking about the classical utilitarian theories and then combining that with the behavior approach. Basically, they talk about precautionary savings, they talk about liquidity constraint, bequest, and habit formation, and then they add that to the life cycle hypothesis, which were all explained in the paper. I'll move forward. So let me come here. So first, they look at savings account ownership prediction, they look at savings accumulation prediction, and then they add that up with the age group effect days. So for the first two, I think it is interesting to look at the younger generation. That is, they use the labor force to predict the younger generation and then compare that with the older generation, 65 and above. And according to the authors, having mobile device kind of predict account ownership. However, people who have the device frequently they save. And the question is, as he rightly said, is it the effect of knowing how to use the device, or is it the effect of having low income and therefore from month to month, even if you save small amount, you have to go in and then take the money and then use it for something else. I think it will have been very good if we have some kind of qualitative explanation to this saving behavior of the younger generation compared to the older generation. Because probably the older generation, it might be difficulty of using this machine that is preventing them from the saving, right? Or is it because they are just keeping the money in for the future, or to bequeath their children or people who inherit them when they leave, when they die? Can we get something to explain that? So I'll move on to this final part. Sorry. The first comment is the paper states that they try to bring a new perspective on mobile banking by looking at the role of devices and technology solution to the savings account ownership and deposit saving. I appreciate the time and effort that they put in because I think this is a lot of work. Okay? And here, by saying that, I say that the paper makes an important and a novel contribution to the literature, both theoretically and empirically. what I expect to see was some kind of tables, if they can, to give the ordinary person how to understand the figures, because some of the figures from the machine learning might not be very easy to understand if you are an ordinary person. So speaking to the average person, what are you trying to tell them? Yes, the keyword is there. Having mobile phone increases access to mobile banking. And that is obvious, we should appreciate it. But I think you could have also include more potential suggestions for policies or solutions to apply to raise the number of mobile banking users in Western Kenya. So in essence, you should have been a little more specific with some suggestions. I'll send you other comments later. Thank you very much for your time.
Thank you, Sam. I really appreciate the comments, and they're really, really constructive. Yeah.
Thank you, Sam. You saved us 3 minutes. So what we're going to do now is move on to the next paper, the paper on user fees on health facilities. Mahmoud, are you the one presenting? Who is presenting the paper?
I'll be presenting it, yes.
Okay, then it's over to you.
Thank you.
So you've got 15 minutes and I'm going to be strict. Meanwhile, if you have a comment or a question, you can wait till the end of the presentation, or you can ask it in the Q&A chat session unit. So you are on.
Thank you. Okay. Can you see my presentation right now? Can you see my?
Yes, yes.
Okay, great. Okay, so the paper I'm presenting today has the title "User Fees in Healthcare. Is it always evil to impose user fees in healthcare?" And we are trying to see the evidence from family planning, maternal and child healthcare services. As we all know that the effect of introducing or increasing user fees in low and middle income countries is controversial. So on the one side, or on the one hand, it's user fees are usually considered as an effective means of generating revenue, and this revenue can be used to improve the quality of healthcare services. But on the other hand, user fees can constitute a barrier to access health services for the poor, and thus it can decrease the utilization of healthcare services, which can be very worrying. And we all know that the majority, if not all, of low and middle income countries are resource constrained. So policymakers should be trying to use the resources wisely in the healthcare system. So the controversial evidence in the literature actually motivated our study to, we have two main objectives. The first one is to estimate the medium-term effects of introducing user fees on the utilization of family planning, antenatal and delivery care services, in addition to women's access to healthcare and child health status in a middle-income country setting. The majority of the evidence is available on low-income country settings, and by default, it should argue that user fees will be like a very heavy burden on the poor. But is the evidence different, or will the evidence be different in a middle-income country setting? This is the question we are trying to answer here. And our second objective is to try to expand the knowledge on demand-side financing with respect to the impact of perception of the quality of services on willingness to pay. To give you a quick background on the health sector reform program in Egypt, and to give you like a background on why Egypt introduced a health sector reform program. Actually, in late 1990s, the healthcare system suffered from a number of challenges. So the government of Egypt tried to introduce like a comprehensive reform program to address these challenges, ranging from poor health outcomes, high maternal mortality, high child mortality. The system suffered from inaccessibility and inequity to access healthcare services. Less than 40% of the population was health insured. We have 5-to-1 geographical disparities in maternal mortality and 3-to-1 geographical disparities in child mortality. And the system also suffered from inefficiency, combining the financing and provision functions of the healthcare system, as well as the underutilization of healthcare facilities. Fourth, the poor quality of care was a fundamental challenge, and maybe this was what explaining the underutilization in the healthcare services. And finally, the system suffered from financial instability. The government was trying to expand coverage without the adequate financial resources. So against this background, the government of Egypt introduced the health sector reform program, trying to improve population health, the population health status and well-being through a universal coverage to a basic package of primary healthcare services. And second, to improve access to efficiency and quality of primary healthcare services. The health sector reform program introduced a number of interventions, and we tried to group them into two main groups. The first component of the program was a service delivery component, under which primary healthcare infrastructure and equipment was renewed. Healthcare staff was subject to training programs. A facility accreditation program was introduced to ensure the quality of care provided in healthcare services. So this is the service delivery component. The second component is a financing one, under which two interventions were introduced. The first is the channeling of funds from direct to performance-based financing of healthcare providers. And the second intervention, which is our one of interest, is the introduction of user fees or co-payments. So the last intervention, as you can see here, the user fees one, is the only demand-side intervention introduced under the health sector reform program. And this is the one we are trying to estimate the impact of. So to probe deeper into this intervention and to give you a quick overview of the cost sharing under the health sector reform program, as per this intervention, now uninsured beneficiaries are required to pay registration fees of about $1 per enrollee, and for each family $2. And also the beneficiaries are required to pay annual renewal fees in the facility they are going to, and they are required to pay co-payment fees. And this is actually the critical one, because now beneficiaries are required to pay a third of the price of medical treatment, including drugs and other therapy. And this is the one we are actually concerned about, that it may like dampen the utilization of healthcare services and like be kind of disincentive to the poor to go to a healthcare facility and use the health services. But under the program, there was an exemption policy for the poor. So the poor were officially identified by the Ministry of Solidarity, and they were supposed to be officially exempt from any user fees at the point of service. But unfortunately, we don't have evidence on the actual implementation of this part. Did the poor actually knew that? Did actually the poor know that they were exempt or no? We don't have any individual level data on this information. So this is the case for reformed facilities. Now co-payments are introduced, but with respect to unreformed primary healthcare facilities, uninsured beneficiaries are charged just like $0.06, which is actually nothing. So they actually pay nothing per examination, and they pay nothing to register at a healthcare facility, and pay nothing when they receive drugs at primary healthcare facilities. So just to give you like a quick comparison between both groups of facilities. And this is like the pathway we were just discussing, the pathway of the reform program. So at the beginning, all facilities are unreformed, and then they were subject to the service delivery component interventions. After this stage, they become accredited facilities. So these facilities introduced all 3 interventions under the service delivery component. And then just a fraction of the accredited facilities go through the second stage of reform, which is the financing component one, under which healthcare providers were paid based upon performance, and under which like co-payments were introduced. And facilities that were subject to those 2 interventions are denoted by contracted facilities. So contracted facilities are those that were subject to both stages of the reform. And in Egypt, we have about 5,000 primary healthcare facilities, almost to give you like an indication of how much the program was a huge one. 50% of all those facilities underwent the first stage of reform. So out of the 5,000 healthcare facilities in Egypt, more than 2,500 became accredited. About 15% of these, exactly 763 facilities, went through the second stage of reform. And as economists, we know that introducing user fees are expected to drive demand for health services in 2 opposite directions. So on the one hand, the negative price elasticity of demand suggests that demand is expected to decline, because the price that the individuals are paying the consumers are paying actually increased. But on the other hand, and this is our hypothesis, the hypothesis of this paper is that services that are subject to fees maybe are perceived to have higher quality, and
you have 5 minutes to go.
Okay, and this may like increase the willingness of pay of consumers to these facilities. So we are not certain which effect is greater. We use a different strategy. The typical one, where the Y is our maternal and child healthcare outcomes, and we have here co-payment to the introduction of user fees, and delta is actually our coefficient of interest, denoting the effect of introducing user fees versus the counterfactual, which are the facilities that didn't undergo any change of the reform. And to account for selectivity bias, we also used a second model, which is the diff two-way fixed effects model. And here we have like time fixed effects, we have group fixed effects, and we have like the policy variable denoting the introduction of user fees by facility I at time t. So our dependent variables are, we try to make use of all the variables in the DHS demographic and health survey data, family planning, antenatal care, delivery care, access to care, and child health status indicators. And maybe the novelty of this study is that we didn't depend, or we didn't rely on the self-reported facility data, but we joined the women using the GPS info of women. We joined them to facilities, and to save time, I will show you like a chart that may make this like sensible. So here we used like a special program to try to link each woman to her nearest mapped facility, to have like a panel of facility level data without relying on facility delivered, on information delivered from facilities themselves. We were afraid from misreporting. Our explanatory variables are the treatment variables, denoting the introduction of co-payments, as well as a list of facility level and district level controls and regional dummies. And like concluding by the results, here are the results of our different estimations. And as you can see, we didn't find any negative effects of introducing user fees on our health outcomes of interest. On the contrary, we found like some significant positive effects on the antenatal care health outcomes. You can see them in bold. We detected some positive effects here with respect to antenatal care. And using our like two-way fixed effect diff model, which report the selectivity robust effects, we can see here in the first row in bold that although we didn't capture any positive effects of introducing user fees, no negative effects were reported. So last slide. To conclude, our findings show that user fees don't necessarily constitute a barrier to the utilization of family planning, maternal health, and child health services in middle-income countries. On the contrary, introducing user fees may attach value to health services by associating them with higher perceived quality, and we will probe deeper into this point empirically. We are working on this part actually right now. So caution needs to be exerted. Thank you very much.
You actually saved us a minute. I appreciate that very much.
Thank you.
Discussant, Boris, are you ready? Boris.
Yes.
Are you ready?
I thought I was discussing a paper by Mossy. That's what I saw on my.
We were going according to the who was putting what, according to the name, the order in which your name appeared.
Oh, okay. Well,
That's
okay.
what my email.
I think there's a mistake in there. For some reason, Mahmoud was actually listed as the discussant.
Yeah.
Mahmoud?
So,
Yeah, unfortunately.
She cannot be a discussant on paper.
Yeah.
If I may ask one question to the honorable attendees, maybe they can advise us on a particular issue if they are interested.
yes, I mean, I have a question about, not actually question, I just want to clarify, when you say that you linked actually the health facilities with the individual by using the distance from the healthcare, and so what was the strategy that you used, that geospatial analysis that you've done there? Can you elaborate a little bit on that?
Yeah. Okay. Can you see my screen or?
Yes.
Okay. So what we basically try to do is that we use in the DHS surveys, we have data on the on women, the GPS info of women. Okay, and we have from so this is chart here, figure number 2. We have the GPS. So these the yellow dots are the women interviewed by the Demographic and Health Survey. And in chart number 1, we have the polygon data of the district boundaries in Egypt. Okay, so first we merged them together, the district boundaries in Egypt, with the GPS info of women. So we get chart 3. So now we know each woman is residing in which district. Okay, so this was the first part, and we used QGIS. This is the program. It's a free program. This is the one we used. In the second stage, so here in the first stage we linked women to districts. In the second stage, we linked facilities to districts. So here the green dots are the one of facilities, and we obtained this info from Egypt's Ministry of Health. Okay, so we link these dots with, again, the polygon info in figure 1 of Egypt district boundaries. So we get chart 3. So now we know each facility is located in which district and each woman is located in which district. The final stage, something like this chart. So now we have a 5-meter radius for each woman, and we can link her to the nearest primary healthcare facility. To do this, we had this was the first stage, and after that we had we have to collapse the data and calculate the outcomes by facility, because again the DHS survey doesn't provide panel data. So we wanted to rely on panel data. So panel data should be facility level. We don't have panel data for women. So we collapsed this the information we had and calculated facility level indicators for each of the survey waves. And we had 6 survey waves. So for each of them, we calculated the health outcomes at the facility level for each of the rounds. And then we have like the panel of facility level outcomes, and we use this to, we fit this like in the model we had.
Okay, so I mean, I was asking that question because, say, if you join a polygon with actually point data, because for each individual you have the lat and lont, right? And for the district, you actually have the polygon. If you join them, it can happen that some of the point that actually fall on the boundaries of, for example, 2 districts. So how do you make the decision which one they will belong to or not?
So because we had this on 2 stages, so first we tried to allocate each one to a district and facilities to district. So now we have all the data within one district, which is this one. And then within this circle, we can allocate each woman to her facility. So we try to reduce the error from like having women residing on the borders of districts.
Yeah, well, I had a suggestion for that. For some of those things that you could want to do is you could use, again, I'm talking about machine learning, but we'll use a KNN, which is try basically to minimize the distance. You can use measure, for example, most one use the Euclidean, which is basically trying to minimize that. And by doing that, the data actually through that algorithm will allocate people in their respective district and facilities more systematically than going through stages that you use, which is pretty much rely on just the mapping, while actually the data itself will be used and harnessed to do this work. So it was kind of suggestion that, yeah, that question was dragged into.
Thank you very much. Yeah,
So
we'll try
all
this.
implicitly assumes that it assumes that a woman visits the nearest facility, not necessarily the facility that she is comfortable with, right?
Yeah, because actually under the reform program, each woman is, when she's using a public healthcare facility, she is using the one in catchment, so she cannot bypass and go to a second facility. Her file is in one facility, so she cannot like bypass and go to like a farther one because like it provides better quality or something like this.
Now, question, can you comment a little bit on your results? Because you were expecting to find some negative effect, but apparently you don't find it. What may be causing this?
Okay, so
Just
yeah, this is a very interesting question indeed, and we probe deeper into this. So the thing is that actually these women are actually were actually paying out of payments, a lot of out of pocket expenditures to private facilities. So if you provide them with a service that, okay, it's attached with money, but this money is actually nothing compared to a private healthcare facility, you can encourage her to go there, especially when we are talking about things like the iron supplementation. So here the iron supplementation is provided for free. Okay, but the antenatal care visits, they should pay for it. But because they know that if they did these visits with a private healthcare facility, they will pay actually almost a 50% higher price. So if you improve the quality, like a quality or the perception about the quality of service provided in the facility, and it's a kind of attaching value to the health service provider. So even if you like impose a co-payment, they are willing to pay for this facility because they compare this service to a private one. And maybe like this can distinguish the results of a middle income context from a low income country context. In a middle income country, we have like the out of pocket expenditure are like 60%, 70%. So they are actually paying, but they are paying elsewhere. So why don't we channel these to the public healthcare system? That was our argument, but we are like trying to do to prove this empirically.
Okay, let's move on. Paper number 3, preparedness. Who is presenting it? Is that Iman?
Yes.
Okay.
Hello, can you hear me?
Yes.
Yeah, I joined just to save Amira from presenting 3 papers, so I will present our paper today.
You are on. When you are ready. To share.
Okay, I will share my screen. So, can you see it?
Okay, you're on the clock now. 15 minutes.
Okay. So hello everyone. I can see familiar faces from last year's AFIA conference in San Diego. I'm glad that you all are safe and sound. So our paper now, I'm presenting on behalf of Dr. Mahmoud Mohiuddin. Actually, he's attending an IMF board meeting, so he cannot make it to today's presentation. Our paper is on disaster preparedness, health disaster preparedness, if they can change the game and mitigate the health impact of disease outbreaks. Actually, in light of the current COVID-19 pandemic, we all know and we all noticed a severe disruption to health services all around the world. Especially, of course, in low middle income countries, this disruption is magnified. And we can see that the disruption actually led to more and additional maternal and child mortalities all over the world, of course, and in the low and middle income country context especially. As women and children are the most affected in all cases, they have lost access to like 20% of health services in result of the current COVID-19 pandemic. And actually about 13.5 million children in the whole world have missed life-saving vaccination in the first 4 months only of 2020. And we expect that some other countries in low and middle income countries will never receive actually these shots. Our figure here shows that we have additional 1.2 million children and over like around 57,000 mothers could die in the first 6 months of 2020. This is based on a WHO report in 2020. And actually these figures triggered us to survey the literature on how the empirical literature actually on how the disease outbreaks can affect maternal and child health. And we found actually that few quantitative studies examining the various effects of disease outbreaks, pandemics and epidemics. And actually some of the few conceptually and statistically only address the effect of disease outbreak on maternal and child mortality at the micro level and in single country context in the low and middle income countries. And of course, a lot of these studies addressing the Ebola outbreak effect in West Africa. And some of them also are addressing the current COVID-19 pandemic effect. Actually, overlooking the indirect effect here is the accounting all the damages of the pandemic and epidemic other than the infection risk. So overlooking the indirect effect, of disease outbreak, and as well overlooking the disaster mitigation measures that we should adopt as low and middle income countries to address these effects is the reason why avoidable maternal and child mortality continues to be high, and we cannot address such obstacle in SDGs and in low and middle income countries agenda as a whole. That's why we seek here to answer three main questions. And we seek to quantify the indirect impact of pandemics and epidemics on maternal, under 5, and neonatal mortalities. And we seek to examine the role that the health emergency preparedness actually plays in mitigating the effects of disease outbreaks. And as well, we dig deeper in the other significant mitigators or mitigation measures of disease outbreaks, among which we have universal health coverage, we have health emergency finance, we have WASH coverage, and we have education, gender equality. Our empirical strategy actually depends on both the health economics literature and the natural disaster literature. And of course, we have the guru of the natural disaster literature, Noe 2009, and Farahani from the economic literature. So we depend on models, a two-way fixed effect model. And we have here our model estimating the health disaster impact. Our coefficient of interest is actually gamma 2 of the disaster, the IT. It's the disaster is like the epidemic and pandemic disaster variable. And the second model is estimating the disaster mitigation effect, which is the interactor in which Z is like the mitigator factor itself. Our dependence either maternal mortality ratio or under 5 mortality rate. Data from from the indicators, 3 actually independent variables, dependent variables. And for the disaster data, we land on the MDAT data, the International Disaster Dataset from CRED. And we use actually 2 variables. The first one is the occurrence of, itself of the disaster, and it's a dummy variable. The second one is the number of people affected. And we divide that by the population size in the year prior to the disaster. And we have the XIT, the controls, which account for the determinants of maternal and child mortality. And they categorize in 5 categories. The first one is economic, second health, and education, gender, and also urbanization. And for the mitigating factors, we have like 5 pillars. The first one represent the health service coverage, and we use for that the universal health coverage data and the physician's density. And we have the public health emergency management pillar, under which we use the International Health Regulation Index from the WHO, which is composed from 13 core capacity indices. We choose from them surveillance, response, preparedness, and risk communication in order to address the effect of preparedness on mitigating the disaster effect. And we have the third pillar, which is health emergency plans. We have ODA, sector, remittances, of course, GDP per capita, savings, and financial inclusion. Fourth, we have the water, sanitation, and hygiene coverage for our 111 countries. And last, we have education and gender variables. Okay, our results show a significant effect. Actually, it's an adverse effect of pandemics and epidemics on maternal mortality and child mortality as well, under 5 and neonatal, and this magnified effect on maternal mortality ratio. We have consistent results using the dummy variable and using the affected people variable. When we isolate actually the low middle income countries from high income countries, we find an interesting result that all the effect actually is coming from low middle income countries, and actually high income countries are not affected significantly from health disasters in our two models. So the effect is coming actually from low and middle income countries, and we can see that the coefficient of maternal mortality is 40%, which is a very big coefficient. We have been through other robustness checks models, and we use two-stage system GMM, and it yields interesting results, the same results as well for low middle income countries. This is actually for the quantification of the disaster effect. When we come to our next model, the second one, the mediating factors of health disasters, we run it actually in low and middle income countries, since the effect actually is coming from this group of countries. And we find that universal health coverage has a significant absorbing effect. It's actually absorbing 4% of the effect from pandemics and epidemics on maternal mortality. This effect is like lower, the absorption effect of universal health coverage is lower for mortality as well. And interestingly, we find that the overall coefficient of health system capacity is significant for maternal and child mortality.
3 minutes to go.
Okay, as well as preparedness, which is our coefficient of interest. But as well, you can clearly find that preparedness, however, it has an effective absorption capacity for disaster effect. However, universal health coverage, for example, has a bigger impact, as well as, of course, GDP per capita is the king here. But we have like financial inclusion has a bigger effect as well. And interestingly, remittances for child mortality has a significant effect as well. When we come to our other mitigating factors, we can like, of course, find WASH coverage and education and gender equality is more effective than preparedness and emergency preparedness, especially for maternal mortality, with bigger coefficients. So in order to conclude, we have like our results show that health disasters, epidemics and pandemics do have a significant impact on maternal, under 5 and neonatal mortality worldwide, but this impact is significant in low and middle income countries. And of course, we expect, and we notice already, similar patterns during the current COVID-19 pandemic. And we expect that this effect is to magnified through the years. And in order to absorb this effect, especially for COVID-19 in the next years, we have to do something about public health emergency management, especially preparedness, in order to build on the significant effect of preparedness in preventing negative spillover effects from health disasters. And not only preparedness, but we have to keep an eye on other mitigators like health emergency finance, universal health coverage, education and gender equality, risk communication and WASH coverage. To our last slide, we conclude with policy toolkits for maternal mortality and child health, or maternal health and child health in low and middle income countries. So governments in low and middle income countries should ensure universal health coverage, decent universal health coverage for all, promote equal education opportunities, especially for women, increase women's access to financial services, and close financing gaps to achieve universal access to WASH coverage, and improve women's economic opportunities and empowerment. And fourth, child health, in addition to these 5 policies, we have to keep an eye on remittances as well. Thank you all, and I'm happy to receive any comments from you.
All right, I am the designated discussant. As we all were discussing earlier on, I didn't have the opportunity to read the paper before the presentation.
We're sorry for that.
Oh, it's okay. It's a problem that apparently you guys didn't even know that you were supposed to. Paper was accepted. So this paper seeks to answer 3 main questions. What is the indirect impact of disease outbreaks on maternal, under 5, and neonatal mortality? It also seeks to answer the question, what role does a health emergency preparedness play in mitigating the effects of disease outbreaks? And last but not the least, it seeks to answer the question, what are the other significant mitigation of health disaster effects? Now, my main, one of your conclusions was that the impact is larger for developing countries, basically, than other areas of the world. And I hope that in your paper, you discuss that thing further, because if you look at the health outcomes that you used, neonatal mortality and all of that, if you compare the numbers for developing countries to the rest of the world without the pandemics, the developing countries are already doing worse, right?
Yeah, of course.
Right. So in that sense, like if you look at the United States of America, what the pandemic, this current pandemic, the impact it had on healthcare outcomes was different. It wasn't about mortality with like childbirth or anything like that. But the other things, elective surgeries and all those things that people couldn't have access to in this country either. So it's a matter of what outcome you are looking at that will determine the impact, because I am quite positive that the elective surgeries in Africa was still going on during the pandemic compared to here. So that's a part I think you need to discuss that further so that you don't overgeneralize that statement. Can you go back to your first results table? There's something I noticed that I wanted to ask you a question about. Here, yes.
This one?
Yeah, this one. For all of your, the disaster ones, you see that every one of them, the affected people, I didn't see it well, is the MMR one, that the affected people, the magnitude of the impact is way larger. The other is the reverse. Is there a reason why this is the case, where the disaster dummy for the MMR is much lesser than, like comparatively, than the other health outcomes? That's another one.
The
Yeah.
magnitude of disaster dummy compared to affected people, right?
It flips. If you look at it, it flips from the MMR to the U5 and the NMR.
Mm-hmm. Yeah.
So that's another part that I hope that you guys can dig deeper and discuss about that. The other part, when I mentioned about the previous, I haven't looked at your model, but did you guys control for the lag of these health outcomes in your model?
Yeah, in the robustness, yes. In
Okay.
the robustness two-stage system GMM, we accounted for the lag and the long-term effect, yes.
Okay. Well, I think this topic is timely, given what we are going through, and thanks for giving me the opportunity to listen in on this. Thank you.
Thank you so much for your valuable comments and questions. And I think for the first thing, which is, of course, the disparities between high-income countries and low and middle-income countries. And that's why in the first stage, we used two-way fixed effect models, and we accounted for country fixed effect and time fixed effect in order to include in our model, or to fix in our model, the characteristics of each country. And of course, we included in our 4-vector control determinants variable here, XIT, all the economic, health, education, and gender risk factors for each country by country. And we have like 111 countries in our model, so it covers actually everything. And when we used our robustness check, the two-stage system GMM, we accounted for the long-term effect using the LEGY-IT. In order to account for not only this actually is the short-term effect. So we have the short-term and the long-term effect, and we discuss this in details in our paper. And of course, we will share with you our paper in order to have a look at it. As for the effect for maternal mortality in contrast to under 5 and neonatal mortality, I think Amira can help us on this. Amira, are you there? So she's not here, I think.
I suspect there's, given the nature of pandemics and given the nature of global nature of health technologies, I suspect there's a lot of cross-country correlation going on, cross-country effect going on, that your system GMM doesn't pick up. And probably at some point, you may want to try and check it up as part of your robustness check.
Yes.
Okay.
Yes. I think. Yeah, Amira is back. So
okay, go ahead.
Yeah, like responding to Christian comments on our model, and he's asking why the maternal mortality coefficient is higher than under 5 and neonatal mortality.
Again, I suspect probably think about possible differences in measurements. If the units of measurement are different, it is possible you get that differences in coefficients.
Yes, this is. I was trying to unblock the mute. Yes, your point is valid. Yeah, because the maternal mortality ratio it's calculated per 100,000, but the under 5 mortality rate, it's the maternal mortality ratio is actually estimated using like a model, but the under 5 mortality rate and the neonatal mortality rate, it's per 1,000. So I think they are different in the way they are calculated or estimated.
My main question was actually about not the size of the impact. That I understand. I was really referring to how the difference between the dummy and the affected people switched. Because if you look at the MMR, in the first one, the disaster dummy is smaller than the affected people dummy, the affected people variable. But if you go to the U5 and the NMR, that is the reverse, where the dummy is bigger than the affected people. And that's what I was trying to see, if there could be some theoretical underpinnings to it. So and also maybe in your table, underneath your table, you need to.
And can we move on to the next paper, and then we come back during the discussion session on this?
Okay.
Okay.
So we now have the last paper on innovation and productivity. Mahmoud, is that you again, or who is presenting?
Yeah, I will I didn't prepare a presentation, but I'll give you like a quick overall view of the paper. And
okay. All right.
Okay.
Go ahead. And again,
yeah, I'll be very quick.
When you are ready to start, let me know and I'll start timing.
Okay, I'm ready now.
All right.
Thank you very much. So this is a working paper that we've been working on at the African Development Bank. The main objective of the paper is to try to estimate the determinants of innovation and hence productivity in developing economies, and we try to focus on African countries to try to see if these determinants actually differ. So so our data set includes a set of 52 emerging and developing economies, in which we compare Africa to the rest of the low and middle income countries. So it's a kind of it's a good data set. And we try to use a novel approach, which is the generalized structural equation model, in order to estimate the causal links between R&D, innovation, and productivity while accounting for indigeneity. And this is the main contribution of the paper. So here we are and we'll come to the model later, we are taking the determinants at the 3 stages. The first stage is the determinants of our R&D. The second stage, determinants of innovation with R&D as an input. And the third stage, the determinants of productivity with innovation as an input. To give you a quick overview of the main findings of the paper, we found that access to finance has the strongest effect on firms' decision to invest in R&D in all countries. So in all our pooled sample of low and middle income countries, but the magnitude was larger with respect to African firms. As for innovation, the drivers were almost similar for all developed economies, but again, we found heterogeneity with respect to African firms in terms of access to external knowledge, and our proxies were access to ICT, or in simple terms, being able to use an email and having a website. So these are our proxies for access to external knowledge. So we found a significant impact of these 2 determinants on the innovation for African firms. This is one. And second, we found also a higher significant impact for skills development via on-the-job training for African firms. So this is with respect to the second stage, which is innovation. As for the third step, or productivity, we found that innovation is the key determinant of productivity in all countries, but the evidence is much stronger for product innovation by African firms. So just I'll go straight forward to the model to give you an idea of what we are trying to estimate here. So we try to use we are using a structural, generalized structural equation model by Crepon, CDM model, to integrate the links between innovation inputs, innovation output, and productivity in a recursive framework at the firm level. So as you can see here, we have the model constitutes of three equations. The first one is the knowledge generation equation. Okay. The second one is the innovation output equation. And here we have knowledge generation, or R&D, as a main determinant, in addition to another set of variables. And the third stage here is firm productivity. And here we have innovation output from the second stage as a determinant. And also, so this framework actually allows us to account for indigeneity while doing the estimations recursively, the three equations. And then maybe an interesting feature here is that we included a latent variable, L, in both. So this latent variable we are including in all three equations following Christopher Baum's model to account for any unobserved variable bias, especially when we are talking about low and middle income countries. So most probably we are not capturing everything. So we included a separate variable, latent variable, to capture all omitted variable bias. So this is our model. To give you also an overview of the data, I'll go straight forward to the data table. Okay. So when we are talking about the third stage, so going from down to up, the third stage is firm performance or firm productivity. We are using two variables. The first one is labor productivity or sales per worker. And the second one is total factor productivity, which is the revenue-based estimates computed as the residual term of the transformed production function. So this is like the dependent variable of our third equation, firm productivity. With respect to our second equation, which is innovation output, we are using three variables to capture innovation at the firm level. The first one is product innovation. The firm is asked in the enterprise survey if it has introduced new products and or services in the past 3 years. Also, the firm is asked if it has introduced improved process in the past 3 years. And finally, we have a direct question to the firm if like it undertook any form of innovation, either product, process, or both. And moving up to the first equation, which is the R&D one, or the knowledge generation one, we are using a dummy variable which switches on if the firm spent on R&D in past fiscal year. And unfortunately, we don't have like enough information on the amount of R&D, but we have like a dummy that switches on if the firm actually spent on R&D in the past fiscal year. And we are using a set of other determinants in all three equations to try to capture the firm's internal capabilities in terms of size, physical capital, human capital, and ownership structures, the firm age, and product concentration. So these are kind of our control variables. The second set of determinants are the access to external knowledge. And actually this set is one of the ones we are interested in because we found that simple things like email use and website ownership can like be a key determinant for the firm to innovate, or can like facilitate the process of innovation by firms. And our third group of determinants includes demand pull factors such as export orientation and international competition. And finally, our final set of determinants include all the outstanding barriers that a firm can face in terms of inadequate education, credit constraints, energy intensity. So we try to be as comprehensive as possible doing our estimations. Okay, and moving to the results. In this table, we are reporting the results of the first equation, which is the R&D equation or the knowledge generation equation. We are reporting the results for the pooled sample for Africa and for emerging countries. And as you can see here, that firm access to finance in the pooled sample represents one of the key determinants of the firm's decision to undertake R&D. And again, when we segregate the results, we found here that it's also a significant determinant for Africa, and actually it's the highest in terms of magnitude and significance, highest significant determinant for a firm's decision to undertake R&D. So these are like the results of our first equation, and here the latent variable is constrained to 1. But in the second equation, it will the coefficients will be estimated, and we are including a set of industry, country, year effects to account for any unobserved heterogeneity. As for the results of our second equation, which reports the determinants of innovation output, we found that with respect to Africa, access to external knowledge plays a very important role, incentivizing the firm's decision to innovate, to undertake product and process innovations. So it plays a very significant role here. And again, it's significant within the pooled sample, but we know that this significance is actually driven by the African firms. And again, the skills development via employee training or on-the-job training plays also a highly significant role in African firms' decision to undertake product or process innovation. And you can see here that the effect of training is the highest in Africa compared to even like the sample of emerging countries or firms in emerging countries. And consistent with the literature, the main determinant of innovation is spending on R&D, which is actually based on the theory, the R&D innovation productivity relationship. And the latent variable here is significant for the pooled sample, so it's actually capturing the unobserved effect in our estimations. Finally, we report the results of our the last equation, or the firm performance or the productivity equations. And consistent with the literature, we found that innovation from the second equation is the key determinant of the productivity of firms, and the same applies in Africa, but but it's significant only for product innovation and not for
4 minutes more
process innovation. And again, our latent variable is significant, so it suggests or confirms that our specification or our concerns that we are trying to capture unobserved heterogeneity, our concerns were valid, and we were on the right track, trying to use a comprehensive framework to capture any unobserved heterogeneity and to control for or to address indigeneity in these very sensitive installations. Thank you very much. We did this paper 6 months ago. I tried to summarize it to the better I could. I hope I have been I haven't like murdered the paper to you. Thank you very much. And actually the paper is available on the website of the African Development Bank. Thank you very much.
Thank you, Mahmoud, for doing such an excellent job in a very impromptu way. I really appreciate it. Let's see if we'll have someone do an impromptu job in discussing. Boris, are you available? Boris.
Yes, I'm here.
Yeah.
But I don't know if I can talk much about the paper.
You are down as the discussant.
Okay, one second.
Okay. If Boris cannot talk about it, anybody has comments, questions?
Just a little comment.
Okay, go ahead.
Okay, so I think this paper is very interesting, especially considering the use of innovation. And in the paper, you comment on two types of innovation: product innovation, and then
Process innovation.
And the product innovation is like if the firm has introduced some kind of a new product within the past, is it 2 or 3 years?
Yes, yes, exactly. This was the question by the World Bank Enterprise Surveys, yes.
Yes, yes. So the key point is how often, if you look at the frequency of the data, what percentage of companies on the continent introduces new product within this defined time limit that you provided? I did not see you speaking about that kind of.
Okay, so you are asking the firms that switched on, so they were like not adopting process innovation. Okay, so if you allow me to share the screen, 1 second. Can you see my screen right now?
Yes.
So here we have like, these are like the descriptive statistics. So if, I don't know if you can see my cursor, but we have like, with respect to process innovation in Africa, 24% of firms reported that they undertook process innovation within the last 3 years. But we don't know if this is the first time for them to undertake process innovation, or this is like a kind of continued process. The same, and you can see the results. We tried to compare the results to the other developing and the emerging market economies. So we just know that like quarter of the firms in Africa undertakes process and product innovation, but we don't know in the sample if it's the first time to do so.
One more comment. Yesterday, when we were discussing in one of the sessions, the issue of training for new graduates came in. And in your paper, I have seen that human capital, that is in terms of high school completion, has significant effect on this productivity. Is it product? Yeah, knowledge generation has significant effect in table 3, where you talk about knowledge generation. So the question here is, why did you take high school graduate completion, but not tertiary education completion as the human capital skill?
Okay, so in table 3, the issue with this data is that sometimes the variables are not available for in some of the African countries. So even when we tried to run this estimation, we didn't use in this one the education directly. We used the inadequate education reported by the firm as an obstacle, and it's actually a categorical variable ranging from a minor obstacle to a very severe obstacle. The direct, here the high school completion, the data is like, it's not, even the high school completion, the data availability is not fine. So we try to complement this with inadequate education being reported as a barrier. So for tertiary education, the data is very limited in the enterprise survey, unfortunately.
All right, last comment, and then I'll move on. So in this case, like as a bank, African Development Bank is like the bank that can support governments to generate data. By finding this kind of limitation in the data generation process on the continent, is there any initiative from the bank to help countries to at least come up with reliable data that will help some of the researchers, not only bank members, but other researchers across the globe to undertake similar research and other activities?
Actually speaking, I'm not working at the bank anymore, so I cannot comment on this, unfortunately. And this is the reason why I haven't received the emails to join the session. But I think while I was working there, I've been working there for like 2 years. They were doing their best to try to to collaborate with other institutions to as you were saying, to fill the data gap. But right now, I don't know what they are doing, unfortunately.
All right, Kobra, thank you very much.
Thank you very much for commenting on the paper and discussing it at such a short notice. And happy to see you for a second year.
I think this is the question of bank funding data collection. Maybe this is something you would want to talk to Adeshina about. And I think he would like to have a long chat with you on it.
Yeah.
I have one question, and that is, how did you measure total factor productivity?
So the total factor productivity, it's actually provided by the enterprise survey. They are actually providing the estimates itself. So we didn't do the estimations, but how they were doing it, they were doing it as the the residual in the using the constant elasticity of substitution function, and it was calculated as the residual.
Okay.
But
yeah.
because the data was not the coverage was not very huge, we used another variable, which is sales per worker, as you can see in the data table. So we complemented this with labor productivity or sales per worker, because for the higher data, to obtain higher observation number.
There is a lot of evidence to suggest that TFP calculated as a residual is woefully distorted. And hopefully, maybe you might want to discuss that in your paper, that there's a possibility that this distortion would have an effect on your results. There are a series of papers by Eberhardt and Francis Steele on this topic, so you might want to take a look at them.
Yeah, thank you very much for this comment. Thank you.
Yeah. Any more comments? Let me make a general comment and a general observation as the chair of the session. It seems to me that these 4 papers essentially discuss some very important issues relating to economic growth and well-being on the African continent. This is the kind of research that I think young people like you and those of us in academia need to be doing. Just do it and put it on the shelf, even if it is not immediately used by policymakers. At some point, it is going to be informative and helpful to us. I remember in the late 80s, when, early 80s, when Ghana was going through structural adjustment programs. Somebody calling me from the World Bank and say, yeah, we've seen your work. You've done a lot of estimation of production function using translog functions. We are doing structural adjustment, but the elasticity coefficients we have are those that were from the 1960s and early 70s, ones done by Omabo, Nostach, and the rest in their famous book. So basically, we are picking up the elasticity coefficients from the air. We are assuming it and going along. Can you use your methodology to give us estimates? At that time, I said, yes, I'll do it, of course. You go to Ghana and they say the data there, oh no, the data is not available. They think that you do the work, use it to get promotion, and that's when I said, I don't care about promotion. I was a full professor at that time anyway, so don't give me a wahala. They never gave it to me, I never did the work. The point is that a lot of times when policymakers need to make decisions, they have nothing to fall on. And it is our responsibilities as academics to provide those inputs. And what you're doing is providing those inputs. So I appreciate it very, very much that you are hitting important subjects and going on. One thing I keep saying, I mentioned it the last time, and I still will mention it. I sit at a place where we have the opportunity to fund research. And the research can be on Africa, it can be anywhere, so long as the science is good, we'll fund it. If you are not in an American institution, we don't fund you though. But those of you who are in American institutions need money to go to Kenya or something like that, collect data and get your summers off, get research assistant, the rest. This is what I do for a living for now. I'm at the National Science Foundation. Send in your proposals and we will see. If you have any questions, you can send me an email at kjimab@nsf.gov and we can talk. All right. I'm not going to hug everything. I'm going to stop here and then hand over the session to you. If you have any questions, comments, queries, let's do it. I think we have about maybe 18 minutes to go. And so, any comments? Iman, I see you want to talk. Go ahead.
Yeah. Yes. Yeah. So I unmuted the, yeah. Thank you for your enthusiastic comments. Final comments. Can we go back to your comment to our paper, preparedness as a mitigation measure? The cross countries correlation, I think you were talking about something like that.
Cross-sectional correlation, yes.
Yes.
Mm-hmm.
Mm-hmm. What was your comment?
Yeah. You do have a lot of things across countries moving together at the same time. Okay, because you are, if you use your GMM or whatever estimation methodology, you are treating the variables in different countries. The cross-sectional or cross-country units as independent, that there is no relationship across countries. But there are. And because there are
Yes.
cross-country correlation and you don't account for it in your estimation, it leads to bias estimates. And sometimes you even get inconsistent estimates. So one possibility is to try to account for this cross-country dependence. One estimator that you might want to look at is the dynamic common correlated estimator, DCCE. It works pretty well.
Okay.
It's already on in STATA, XTDCEE2.
Yeah, XTDCE2.
Yeah, send me an email and I can give you the appropriate reference.
Yeah, this will be very helpful because it comes to surprise to us that the highly cited paper in this field, like the NOE one in GDE, and the other also Farahani and other health papers use only fixed effect or either GMM. And that's why, yeah, I was eager to hear your comment on that. We can dig deeper in this suggestion, and we can share thoughts with you. It would be very helpful. Thank you so much.
Yeah, because you notice that especially when you're dealing with Africa, almost everything, I mean, especially across regions, if you look at West Africa, you cannot think about anything happening in Nigeria and not happening to Ghana. And so if you treat them as completely independent, you have variables that are highly correlated across these regions. So basically, you don't account for this cross-country correlation, your estimates are likely to be biased. Yes. Especially if you're dealing with movements across country and through time.
Yes. Okay, Amira, we can try this model and share results with Professor.
Yeah, because look, if you do it and you don't find any difference, fine. At least you have checked.
Yes,
and said, this is another proof. My model is stable.
Yes. Yeah, well, the problem is that we will cause you a headache with our questions, but but we are really happy that someone is here to help. Thank you very much.
Okay. We have 15 minutes or less.
I wanted to
so let's talk. If you have something to say.
At the end of that paper, I have a question, and I wanted to know, when you're talking about disasters, were you just considering pandemics or epidemics, or you consider other disasters?
We consider actually pandemics and epidemics actually it's available, the data is available from 1900 until now on MDAT. Yeah, but we use.
I wanted to see what was the number reading you have for each of those events, if maybe your time span is not that large. So I didn't know that it was up to 1900. Okay, that makes sense to me.
Yeah.
And GDP and all those other measures that you have they were really recorded in 90s for African countries?
No, the data itself is available from 1900, but we use it from 2000 till 2019.
Okay, you should reading for that? Because I'm thinking that in most of the high income countries, reading for epidemics and pandemics wouldn't be that much, right? You won't have many of them to include in your model.
No, actually, we model 111 countries. For all of them, we have observation for epidemics and pandemics because it's epidemics and pandemics, so it accounts for everything. So we have data coverage for the 111 countries over the time period from 2000 till 2019.
Okay.
Okay, those in the audience who I don't see, please jump in if you have a question or a comment. It looks like those of us on the forum are monopolizing everything.
Several of them dropped out already.
We still have 11.
Yeah, so that means we have about 4 more people on the other side.
So please jump in. This is your chance. We do have about 10 minutes to go. But if nobody's jumping in,
actually, I have a suggestion for your kind self as a one member from AFIA. That you account for our personal emails in your mailing list every year, because we wanted to share more papers with you, but no response actually is coming from your side, especially Professor Jean-Claude, I don't know his surname, Muswana, right? So if you permit private emails to be in your mailing list, it will be easier for African researchers to update their papers, share with you their thoughts, and so on and so forth. So we have a mailing list for AFIA members.
If you are
Christian and Samuel, over to you.
Yeah, if you're looking for somebody in particular, you could always reach out to me. I have a database of members' emails. If you want to include your own private email, just also send that to me and I will put it in the mailing list. And I don't know if you guys know, you're supposed to go on our website and register. So if you haven't done that, it's afia1.org. Just go on there and register so that we can have you also in our database, because most of the time we are using information like the conferences and stuff like that. It's only the person that have paid dues, for example, that I have information for, not all the presenters. So yeah, it's just
okay, perfect.
Yeah, send it to me.
Okay, perfect. Thank you.
Prof, I'm sorry, I have to leave the meeting now. It's 8 a.m. here, almost 8, and I have to take care of family business. Sorry.
We've got only 8 minutes to go, so you are excused. And thanks a lot.
Thank you too for hosting
for your
presenters. Thanks a lot. I hope you will communicate and then share ideas later. Thanks. Christian, I'll call later.
All right. Bye.
Bye.
Happy New Year, everybody.
But you are not leaving.
I'm here.
Okay.
I'm not in Japan.
Okay. Yeah. Yeah, it looks like.
So Professor Kouaben, I have a question about the NSF. So you say being affiliated to U.S. institution, does it need to be a research institution, or what do you mean by what any kind of
research institution, university, or whatever?
Okay, including non-governmental institution as well, if they're doing research?
Oh, yeah.
Okay.
Yeah.
Interesting.
We don't fund African institutions because it's
the taxpayer money,
American government money.
Yeah.
And you don't want to just take it and say, okay, we're going to give it to such and such. And And so the money goes to not you as an individual, but it goes to your institution. And then you draw on it from your institution.
Yeah. Okay.
Do you usually, if I may ask something, do you usually collaborate with universities? I'm working as an assistant professor at Cairo University. So do you like, is it easier to collaborate with universities or like with institutions like the African Development Bank, etc.?
No, we do not likely collaborate because we don't have institutional affiliations, and we don't have institutional affiliations with African universities.
Okay.
However, you can have a co-author, a collaborator at an American university or an American research institution, and then you can be a consultant on the project.
Okay, but for example, if I like if I want, like, if I'm working on a project or like I see a potential in a project, how can I approach someone? Can I approach like someone in a university and like discuss with him a project, and like they will be welcoming based on your experience, or it will be kind of weird that they don't?
I'm not allowed to say anything, but you figure it out. If you want to have a collaborator.
One thing you could do easily, this is why we have AFIA, for example. This is where networking comes into place. You can reach out to, just even posting on the platform, somebody will partner with you. So I think that's the whole idea behind having this organization.
Thank you. Like some researchers, like they do the work, but they don't know how to like collaborate effectively, how to like, so that's why we were very keen to attend. Thank you very much.
We have 5 minutes.
Christian, any big news on, I haven't attended the presidential meeting, and any big news from AFIA that we need to know?
Yesterday, we actually didn't have the presidential address. You remember you were in that session when we had, you presented. Normally we had the presidential address before that.
Yeah.
But we didn't have that because the president is actually in Africa.
Okay.
Yeah, she didn't think that her network is going to be able to hold on to that. So she said that she's going to send an email out to the organization with her information later on.
Okay.
We also have a YouTube channel, so I'm going to encourage her to even do a short skit and post it on the YouTube channel so that people can actually see her rather than just email.
Yeah.
So
I think that is not an excuse. This should have been done. All right.
that's why she told us.
No, I'm serious.
Yeah,
She could have deputized one of you to do it.
that's true.
When Augustin Fosu was the president, he was, and he went to Nairobi the first time. I wasn't even an executive member, but I carried on those responsibilities, and I presented the presidential address at the meetings. Okay, the same way when Paul Asabri was the president and he went on sabbatical at KUNST, I presented a presidential address. Okay, you asked Leonce in the same way. So it can be arranged to be done. I think that there are a lot of questions that people needed to, I in particular had questions to ask about the way things were organized. There are a lot of people who are complaining that their papers were turned down. But if you look at this, you can see that a whole set of people having 2 or 3 papers on AFIA sessions, and then we drop a lot of other people's papers. I think this is one thing that basically tells people, well, if I cannot go present my paper, why do I? So we have to find a way to put people on the program, either presenting or discussing.
Yeah,
if you look at our system here, you find out that the same set of people who are presenting are the ones who have been charged to discuss. Doesn't make sense.
Yeah, and another thing is, even we had an issue with the NEA session where they put it at the same time as this session. That's why we didn't even have enough, too many people in this session, because there was no communication between the NEA group and the AFIA group at a certain point. And so that's something that we also have to deal with, because we cannot split up like that, having 20 people there and 15 people here when we can have 35.
We have 1 more minute to go.
Well, it was good seeing all of you. I enjoy my presentation yesterday, today as well. And thank you, I mean, everyone who put together this event. And Professor Kwabena, thank you very much for.
And I thank all of you for your participation. I think you've done a good job on your presentation and your papers. Keep the good work, and please give yourself a big hand. Oh yeah, give yourself a big hand, because I think
thank you.
you've done a pretty good.
Thank you. Stay safe. Yeah.
Thank you.
Bye-bye.
We're going to
Thank
give
you.
up now in a
Take
second.
care, everybody. Take
All right.
care.
Take care. Bye-bye.
All right.
Bye.
Bye.
Bye-bye.
Bye. Bye.